trained in rural family medicine, and now I'm sitting 8 blocks northeast of the White House talking to you about our experience taking a look at telehealth, both across the country and across the world. So very happy to have a chance to connect today and share my thoughts on this. And this is meant to be as interactive as possible. I'm not on the Whova app. I'm looking at the Zoom chats, but Aislinn says that she will babysit me and guide me with the questions that do come in. Next slide, please. So URAC, some of you have heard about URAC, some of you haven't heard about URAC. Let me just tell you, URAC is an accreditation organization. So when you think of accreditors, you think of things like the Joint Commission, you think of NCQA, you think of ACHC, those sort of organizations. We are an independent accreditation organization. We've been around for almost 30, actually over 30 years now. We're nonprofit. We are completely independent. And unlike all the other organizations that I named, we don't sell any consulting services. So I'm not here to ask you to please sign up for our consulting. We see ourselves as keeping an eye on what's best for the patients. So we do accreditations. We've got about 40 different accreditations. We're noteworthy in that we're the only accreditor who does a mental health parity accreditation, and we're the leader in telehealth accreditation. We were doing accreditations in telehealth back before the pandemic started. We've continued to do them. We're on our third version of accreditation. And we see accreditation as being an overview of the whole program. So it's not about just the provider. It's not about the technology. It's about the whole program. And an accreditation, as we say it, is that very often regulation will set a bar for safety, but we see as accreditation as setting a higher bar for quality. Think of it like board certification or something like that. It's more than just the minimum. Another analogy that I draw is when I was practicing, I was licensed to practice medicine in Iowa, Missouri, and Texas. And to be licensed as a physician technically means I could have done a heart transplant, but I wasn't trained for it. So you want to go to somebody who's actually got that extra training, that extra certification to trust them. Our 40 plus accreditations, everything from pharmacy, health plan, health network, population health, utilization management, all different things all over the country and even across the world. Next slide, please. So I want to talk to you about telehealth, and we're going to get to the things about mental health care via telehealth and get into that into some depth. But I want to talk to you about the whole landscape of telehealth and what we see. When I look at telehealth right now, and we work with providers all over the country, across the world, there's some areas where telehealth during the pandemic really sort of found some traction. And I want to talk about those. So pediatrics. In pediatric care, we accredit Children's National, which is here in Washington, D.C. And one of the things they found with telehealth during the pandemic is they were able to do post-op visits where a child would have a surgery and maybe this child lives 500 miles away and they come here for a very specialized surgery. They were using telehealth for a post-op check a week later so that if a child went home and was receiving care back in their home community, you wouldn't have to load up your child and come 500 miles for a 15-minute wound care check, that they could do telemedicine for that type of visit. And that seems to be a good thing. Mental health substance use disorder. We work with a group called MindPath, and they actually do mental health and substance use treatment using telemedicine. And they talk about how this has opened up more doors for them and how people have been able to receive care who wouldn't otherwise be able to receive care. In diabetes, we work with an organization called Glue Care, and they do an integrated disease-specific telemedicine program. And we went through and we checked to make sure they were doing evidence-based medicine and they were doing things right. And that's an example of where we see how disease-specific telemedicine programs have taken off during the pandemic. Correctional health. We work with organizations where they're providing services into correctional organizations, into prisons, into jails, and those sort of things. And we work with a group called Centurion, who's gone through our accreditation and making sure that the care is being delivered appropriately. The FQHC one, I think, is a really interesting one. During the pandemic, people got really creative with telehealth. And the restrictions were dialed back down, and you had a whole bunch of organizations doing telehealth who weren't doing it before. And one of those is AR Care. AR Care is an FQHC located in Arkansas, which is using telemedicine to provide behavioral health care in schools, in elementary schools, in junior highs and high schools in Arkansas. And when you think about the whole landscape, telemedicine can be the big commercial telemedicine vendors, but it can also be a little FQHC. And both of those organizations can come to URAC and go through our standards and go through our process and be held accountable for providing a higher level of care. Geriatrics, the example that we have here is Ann Sham's virtual hospital out of Cairo, Egypt. Ann Sham's was interesting in that during the pandemic, they came to us. We were not actually doing telemedicine accreditation internationally. And they came to us and they said, when we look around the world and we look at standards that are being put out there for what is a quality program, you guys seem to be the leader. And so they asked us to accredit them. And it started off with their stroke program that they do in Egypt. And they do like 27 sites around Egypt where they're doing acute stroke interventions. But also they want to set themselves up to be the telemedicine hub for the continent of Africa. And these are examples of different use cases that I think are very telling as to how telemedicine is not just one big gigantic monolith, but there are specific use cases which are getting traction. And when we talk to regulators and we talk to legislators about what's going on in telemedicine, I often divide the world into two camps. One camp, which talks a lot about fraud, waste, and abuse concerns in telemedicine, is probably going to dial back the availability of telemedicine. And other groups who talk about quality or who talk about improved access are probably going to dial it up. And right now in Washington, D.C., there's this tug of war going on about what's the good part of telemedicine and what's the bad part of telemedicine. Because we can't ignore that there's some bad actors who have tried to come into telemedicine. And they're not trustworthy. And how do you know who to trust? And that's one of the roles that we think accreditation can play. And we've worked with academic medical centers, we've worked with community hospitals, we've worked with innovators and disruptors all over. And that's one of the things that I would say to you is if nothing else, if you want to take a look at what makes up a full telemedicine program, then I would go to the URAC website and I would go into our standards at a glance and go to telemedicine, look at our standards at a glance, and you can see all the things that we talk about, whether it be data security and consent and technology and all those sort of things. But look at what makes up a whole telemedicine program and then see how you would measure up on that. There's no cost in looking at our standards or seeing how you measure up. So consider doing that as sort of an education. We're going to keep growing and keep changing. We saw an advancement that happened with telemedicine during the pandemic, and we're going to keep advancing it. Next slide, please. So I want to focus now back on behavioral health. And I will tell you that URAC did not just show up for behavioral health a year or two ago. We've been involved in behavioral health standard setting all the way back to 1999. We started out with utilization review. That's where the U and the R come from in the name of our organization, URAC. But we're also involved in case management, utilization management back in the 90s. And in 1999, we started writing behavioral health standards into our case management programs. And we've progressed as you go down through the years to see all the different ways where behavioral health has come into our programs. And as I said before, we have like 45 different programs, and we have behavioral health in probably, a third of all of our programs have standards around behavioral health. And so when it came to our expertise in telemedicine and our experience with behavioral health, it was very natural for us to bring those together and to use our experience and our experts to craft the standards that we put into telemedicine and that we look for in a good telemedicine program. And the integrated behavioral health that you see there in 2020, that's one of the things that is how I view medicine, is that health is mental health is health. You can't just carve out somebody's mental health as being part of their health and treat it completely differently. And even though the payment mechanisms may be different depending upon where you're working, when I was a primary care physician, a lot of my patients had mental health issues and behavioral health issues, and I had to address those to take care of the whole person. And we view that whole person care as one of the cores to what makes up a good program and what we're looking for when we accredit organizations. Next slide, please. So let's talk about a nation in need of care. Anybody who's awake and who's been paying attention to this will tell you that the country is going through some issues here. 1 in 3 Americans reported symptoms of anxiety and depression in 2020. I don't think it's gotten better. It may have gotten worse. We have a shortage of providers and a mismatch of providers. 45% of Americans live in areas designated as federal government as mental health professional shortage areas. And telehealth can be one of the ways that we help to close that gap. 42% of adults with mental illness weren't able to get care because they couldn't afford it. That's a problem. These are all signs of issues that we face in America with mismatched care, the lack of access, the lack of quality access, and an increasing need. And as we think about telemedicine as being one of the ways to improve some of those things, it needs to not be a standalone, here's this solution that we're going to keep over here in a box, but it needs to be part of the overall approach to how we look at mental and behavioral health. I do want to mention, we should have plenty of time at the end of this program for questions, at the end of the presentation for questions. So feel free to put things into the Whova chat or into the Zoom chat, and we will get to those, just if you want to clarify any of those sort of things. Also, at the end of my presentation, I've got some references for where some of this data comes from in case you have questions, but I think we're all sort of on the same page at this point. Next slide, please. So I want to talk specifically about California, and this is an incident of mental illness, a survey done in 2019. So this is back in 2019 before COVID. In adults, about 4% had what was diagnosed as a serious mental illness, and the reference is down at the bottom, but 13.5% had any mental illness, and that's just a survey of 2019. So that's just a questionnaire, and 7.3% of children had a serious emotional disturbance. And I think we can all agree that there is a need for treatment for the children, for the adults, for people who are facing these issues. And in 2019, it was there, it was significant. Next slide. So we're actually going to take this chart and we're going to blow it up and put it into some different slides as I go forward. But I want to talk about this. When you look at this, what we have is we have places where we have need, and we have people, and we have a lack of providers. I grew up in rural Iowa, and I grew up in a town of 800 people. We had no mental health professionals in that town. And there's places in California that have a significant shortage. And there's this mismatch between physical doors and where people need the care. And telehealth can give you a virtual door so that can be available to people wherever they may be. And this crisis is probably not going to get better when we look at what's happening with providers and some of them retiring. We have a whole swath of providers who are basically going to be retiring in the next decade or so, and we don't have anybody in line to replace them. And when we do replace them, it's not necessarily going to be in the places where they're needed. Whoops, I just popped my nose. So 10 minutes ago, before this talk started, I'm going to turn off my camera, by the way, because this is embarrassing. I had a bloody nose, and I thought I had it under control, and now I don't. And so I'm going to go to just audio for a second here. Wow, that was a problem. Okay, so in talking about the missing practitioners, down the left side are the different parts of California, and across the top are the various types of professionals who can deliver care. You can see that the numbers, if we go to the next slide, I'm just going to dig down into a certain one of these. So psychiatrists, the state average of 11.8 per 100,000 people is an okay average. It's probably a little bit short there, the recommendation being almost 26, but there's not a single part of California that seems to have 26 per 100,000. You go from the greater Bay Area where you have 18.7 per 100,000 all the way down to the San Joaquin Valley at 6.2 per 100,000. So there's not a single area of California that has enough physical doors for the recommendations for psychiatrists. And I mean, you have a threefold variation from San Joaquin Valley to the greater Bay Area, and the need is still there in the San Joaquin Valley. So when we think about this, how do you get the providers to the place where they're needed? Next slide, please. So let's talk about social workers. The state average, 65.9 per 100,000. I mean, you got the Bay Area again, sort of crowded with 82.8 per 100,000, all the way down to the San Joaquin Valley, which seems to be the short place again at 35.5. So when you think about the landscape of providers and where they're located, it's that mismatch. It's the how do you get the providers where they're needed, and how do you get the care that's needed? And you recognize that some of them are going to be retiring, and we've got this mismatch. And I think whenever you talk about this, we are not going to start busing the providers from the greater Bay Area down to the San Joaquin Valley or out to the Inland Empire part of California and say, well, here's where you're going to be practicing now. And I think that having telemedicine and having good, reliable telemedicine programs is one of the keys that we're going to need to use to move forward with this. Next slide, please. So clinical counselors, this is just the third verse of the same story. The state average of 5 per 100,000. I didn't have a number for what the actual recommendation is like I did with a psychiatrist, but in the San Diego area, you got 7.3, San Joaquin Valley, 2.5. So you have, again, about a third of the providers per 100,000 out in the San Joaquin Valley as you have in the San Diego area, but you even have Los Angeles County, which is half of what you have in San Diego here. The greater Bay Area is 6.8. Apparently the clinical counselors like San Diego a little bit better than the Bay Area, which is where the psychiatrists seem to be hanging out. But when you see this variation, almost every state in the country has these urban islands of providers, and you have these rural areas where you have nothing. And that's a problem. And it's not just a problem in social work. It's not just a problem in psychiatrists or in mental health care. It's a problem for the people and the populations. Next slide, please. Here are psychologists, the fourth verse of the same song. State average 44.2. Greater Bay Area has jumped back to the lead there with 72.6. San Joaquin Valley still 16.2, but the Inland Empire actually loses this one, so they're at 15.9. So San Joaquin Valley did not run the whole table. They had one where they actually were second worst or second lowest number. So significant differences. And this is in California, where you actually have a fair number of providers. There's other parts of the country where the deficits are even worse. And as we think of ways to address that, not just with the providers who are there, but what could we do with telehealth with providers from other states, or from being able to have the best use of the providers that you do have, and making sure that they have making full use of their time and their availability. Because if you're in the greater Bay Area and you have a higher number of providers, are they being used 8 hours a day or whatever their clinic time is, or are they not able to do it? And not only is it the location, we have to think about everything else that goes into getting care. Next slide, please. So adults with an acute mental illness in California, this survey was 2017 to 2019. 36.8% received mental health services. 63.2% did not receive mental health services. And this was before the pandemic. And we've all the studies say that the need has increased during the pandemic, and we've not added a whole bunch of providers that are there, and those that were available because of relaxed regulation with cross-state licensure and those sort of things. Now a lot of those restrictions have come back on, and we're seeing piecemeal solutions across the country as to how we're going to try and continue the access to care that we had during the pandemic. Next slide, please. So when you think about challenges to care, we've talked about just access, and we've looked at numbers pre-pandemic, and we know they've gone up with the pandemic, but all of these other things factor into this, and we've referenced some of them. There's the affordability of care. What can we do so that receiving care isn't just something that the wealthy get to do, and something that the people who live in the big cities get to do? Talk about logistics, and we're gonna go into the various challenges with these sort of things. But in small towns, sometimes people don't get care because they don't want to be seen walking into the psychiatrist's office, or they don't have a car, or it's 3 buses to get there. The uneven distribution of providers, which we've talked about, and doesn't show signs of a great solution for that, for their physical location. So how do we make it so that their physical location doesn't have to limit their practice location? And then there's the remote prescribing regulations. During the pandemic, we saw a lot more prescribing openness. We saw licensure openness. We saw the ability to receive care in ways that hadn't been allowed before, with platforms that hadn't been allowed before. But now we're seeing that the public health emergency has ended, and those restrictions are being dialed back onto being able to deliver care. Now, certain states are keeping basically the openness that they had during the pandemic, but other states are putting the controls back on. And What is the effect of that? And I understand concerns about fraud, waste, and abuse and those sort of things, but there's still that need for care. And we also have patients who have increased expectations for the quality of care and what they can receive. How do we address those? How do we actually make this more patient-centric as opposed to being building-centric or city-centric? Next slide, please. So let's talk about affordability and go into that a little bit deeper. 25% of patients cannot find an in-network provider. From where we sit in the organizations that we talk to all over the country, people will talk about behavioral health care, and they will say that they have a network when they sign up for insurance. And there'll be a list of pages of providers, and they'll start calling them. And what they find is that a lot of the people listed in the network aren't really taking new patients. So that idea of availability is not there. And I'll tell you that the government and the regulators are looking very closely at the things called ghost networks, where somebody has a network on paper, but they don't have it available for anybody to use. And that's a big concern. And I wouldn't be surprised if there were laws and regulations that come out in response to that. And that's if you can find a provider. 40% of patients with mental health conditions can't afford care. The financial pressures with inflation, with all of those sort of things, some providers aren't taking insurance and it has to be out of pocket. 40% of patients with mental health condition can't afford care. What do we do with those people? What do we do? Are we going to be content with a two-tiered system of providing care, or are we going to find ways to close those gaps? And cost has to be one of the things that you consider. And just in my last point there, out-of-network costs can exceed $200 per visit. And this isn't like a sprained ankle where you go in and you get one treatment and you know what you need to do. This can be a series of visits where people need to be seen over time, or maybe they're doing okay, but then they have an acute episode and they need to get in to have care. And we've already said 40% of patients can't afford care, but when it's $200, a lot of people who need care don't have $200 sitting around for every time they need a visit. And how are we going to address those things? Is there an opportunity for telemedicine to present a lower cost accessibility improvement that people can take advantage of? And I think I've gotten things under control here, so let's try going back to video. But at a moment's notice, things can happen. So the logistical barriers to care. What I wanted to emphasize in these slides is, the first thing we have is we have that provider out in a rural area, or what looks like a rural area. And I often talk about growing up in Iowa and the things that we face. I actually come from a part of the country where you don't have cell service, let alone broadband. And people who talk about policy very often are talking from a place where they're educated, they have amenities like broadband, they have computers, they have a nice phone, those sort of things. But how do we address the need in those rural areas where the providers aren't, as we saw from our earlier numbers? The bottom left, what do we do with people who have problems with access? If it's three bus trips and you're in a wheelchair, how are you going to get to the care that you need? And are we going to leave those people behind as we progress with this? Does telemedicine again become that luxury good that we restrict to people who can afford to pay for it out of pocket, or who are able to walk up 3 flights of stairs, or those sort of things? And then the right side, again, as we talked about the idea of stigma, and we talk with organizations, and some of them will say, we had an increase in our services, increase in our access during the pandemic because of telemedicine, because people told us that they were concerned about being seen on Main Street going into the office of the psychiatrist, or running into their neighbor in the parking lot or in the waiting room, or those sort of things. And it opened up more doors, and they were good doors for people to get care who wouldn't otherwise get care. Next slide, please. The uneven distribution of providers, like we talked about, 150 million people live in an area designated as having a shortage of providers. 150 million people. That's just a striking number. That's almost a third. Half of U.S. counties don't have a single psychiatrist. And a lot of those people who need care in those counties don't have a way to getting 3 counties over, or to keep a weekly appointment some other place. And then there's the fact that psychiatrists are getting old, and we have a whole crop of psychiatrists. 55% of psychiatrists were 55 years old or older, and those people are going to be retiring. and who is next? Who's going to fill that space, and how are we going to address that need? Because the need isn't going away when they retire. Next slide, please. The remote prescribing regulations, like I talked about, 15% of adults have a substance use disorder, according to surveys, but 90% of them did not receive care. So if we can get the Americans, the adults who have a substance use disorder, if we can get them care, how do we do that? We know 90% are going without care. And if we want to make a dent in the crisis that we're seeing in the populations with substance use and treatment, we need to find a way to do that. And there were innovative programs done in the United States during the pandemic when there were relaxed regulations around providing care, where we actually saw medication-assisted treatment for substance use disorder where it went up because of the loosening of the regulations. And how do we learn from that, and how do we continue the good without opening ourselves up to the bad? Next slide, please. How to tackle the issue. We believe that there needs to be flexibility for the providers. One of the good things about the pandemic is that a lot of providers who had never tried telemedicine got thrown into telemedicine, and some of them discovered its usefulness and its goodness and its way that it could extend access. We also need to develop community partnerships. And when I say community partnerships, I'm talking about everything from, making sure that the providers are playing well with each other, that the community service organizations have a connection to the providers, a connection to the health systems, that a whole community can be involved in the delivery of care. The parity laws, mental health parity has been a law now for over a decade. And yet, when people look at the delivery of care, we're finding all sorts of times where parity is not being followed in benefit design and in delivery. And we need to be able to say, at a minimum, remember, parity is about is physical health being treated the same as mental health? And it's just, are they equal? There's nothing about that says they have to be great. Is there a way that we can make them not just equal, but maybe both of them be great? And that's probably going to involve some creativity and some delivery of care outside of how we were doing things 5 or 10 years ago. And then track outcomes to demonstrate quality. Whenever we talk about telehealth and we talk about the delivery of services, we're always being asked by payers and regulators, how do we make sure that we're getting our money's worth? And if you want to have any discussion about somebody getting their money's worth, you need to take a look at the outcomes. Now, you should be taking a look at your outcomes because you want to do a better job. And to do that, you have to track what's being done. But also when it comes to telling stories to regulators and legislators and making a case for why the flexibility that we had before should continue, tracking outcomes is incredibly important. Next slide, please. So the flexibility, as we've talked about, telehealth increases the flexibility of providers. You have more slots for patients and more entry points. And we all recognize that those are needed. And they have to not just be in one building next to the hospital where all the doctors have their offices. It needs to be in the small town. It needs to be in the rural area. It needs to be in the jail. It needs to be in the nursing home. And we need to take advantage of that place where we can get the access to the information. Just as an example, how many of you, the next time that you have a trip, are going to be using a travel agent? I mean, I remember back in the 90s when I was planning a trip, I had a travel agent that I had to go through, and now I go on my phone. Is there a way to take the good parts of that access and bring it over to care for behavioral health and mental health? Telehealth visits, also a telehealth visit isn't the same as having somebody come into your office. You have an opportunity to take a look at what their home situation is like. We've talked to a lot of people about telehealth, and one of the people who talked to us about telehealth is allergists. They find that doing a telehealth visit with a patient who complains of severe allergies, that they can take a look at the home and say, I happen to notice you've been complaining about allergies, and it looks like you have 5 cats sitting behind you, or your house is full of ferns, and I know you're allergic to ferns. Have you thought about doing something about that? The same thing goes into behavioral health. And we need to make sure that it's safe and it's secure and people are protected. But understanding the chaos in the world around them in their home can help you to understand sometimes the situation that they're facing with their mental health. We have to look. I mean, if we talk about a shortage because of psychiatrists retiring, we also have to say we need to grow residency programs to train psychiatrists. And by the way, when we grow The residency programs, let's make sure they're able to do telehealth so that they can be efficient and effective when they actually come out of residency to deliver higher efficiency of care. We need providers now. We know that what we have isn't enough and the shortage is going to get worse with retirements. So let's think about all of those tools to try and make good use of the ones that we have. Next slide, please. Community partnerships, as I talked about, the jails, the prisons, the inpatient treatment centers. How do we look at partnering with schools? How do we make sure that like AR care, as I talked about, doing behavioral health care in schools? Just a fantastic project by that FQHC. In the jails, we work with Centurion, as I mentioned in the earlier slide, and then also as an old primary care physician, I can tell you that having community partnerships with the primary care physicians, because the primary care physicians are already providing behavioral health care. And just like they provide basic diabetes care, when someone doesn't respond to the basic care and they need to get into a specialist, we need to have those connections already made so that it doesn't come down to a crisis and a scramble. Next slide, please. So specifically on the parity requirements, the Mental Health Parity Act was written back in 1996. I will tell you, I was finishing up residency in 1996. It's been 27 years since that. And we still know that in 2022, Treasury, Labor, and Health and Human Services filed a report to Congress where they said, we still are not achieving parity. And we know that organizations even have trouble describing what they're doing for parity, and the regulations are growing and the fines are growing. And any organization that's looking at mental health parity is saying, they can't show us what they're doing, and what they seem to be doing doesn't seem to fit the rules and the regulations. So I would look for more activity in parity enforcement rules, whether it be the Department of Labor, because remember, mental health parity laws are actually written as Department of Labor laws. They're not CMS and Health and Human Services laws. This is Department of Labor. So there's going to be significant fines and rulings from the Department of Labor as to how parity is being delivered to employers and employees as they go through healthcare and health insurance. Next slide, please. So as I said, tracking performance to demonstrate quality. And when I say performance to measure quality, I'm talking about things like patient satisfaction survey, but also patient health outcomes. If everybody's really happy with the care that they deliver, but it's terrible care, that's not a win. You need to be tracking both the outcomes and the satisfaction. We're a huge fan at URAC of measurement-based care. We've supported that for a couple years. Measurement-based care is the idea that we're going to screen a population for conditions. We're going to diagnose based on those screens, and we're going to treat until we see improvement in those numbers. At its most basic, that's measurement-based care. And we actually have been trying to highlight measurement-based care as the way that behavioral health care should be delivered. We need to look at prescribing patterns. We've seen large organizations get in trouble with the overprescribing of medications through telemedicine, and that's a concern that we hear voiced by regulators and legislators. Comparisons between staff. If you have 5 providers, are they practicing consistently? Are they following the evidence-based guidelines? Do you have one provider who's overusing a certain type of medication or underusing another type of medication? Remember that prescribing can be too much and it can also be too little. And you need to be doing the internal checks as to how your quality is doing and how your providers are doing. And theoretically, all of these things should circle back into your staff training. You want to know, your staff wants to know how they're doing at delivering good, high quality care, whether it be satisfaction, whether it be, we have people who are improving, here's their screening scores, but here's their treatment scores. Look at the difference we're making in this population. That just gives people a good feeling about that they're doing the right thing and doing it in the right way. So a couple takeaways that I want to leave you with, and then we'll open it up to questions. Next slide, please. So there's a significant difference and a gap in the availability of mental health care across the state of California. And I can tell you every state, except for probably really small states, have significant differences in provider availability. And we see massive deserts for behavioral health care. And telehealth has been a key tool for extending that care into underserved areas. As I say in number 2, if telehealth is an important part of this, it can be when done right. It can also be a problem when done wrong, like any care. So, you're here about telehealth and telemedicine. I will tell you, we sometimes use the words interchangeably, but health is improved with telehealth. behavioral health care is improved with telebehavioral health care as part of an overall plan. It's not a magic bullet that fixes everything. We still got to look at residency slots, and we got to look at training, and we got to look at distribution of providers. But telehealth gave us a taste of how we could extend access and improve care. And if you go back to one of my first slides, it talks about, all the different types of care that we're seeing happen. We need to be supportive of the good actors and not be distracted by the bad actors. And we think, number three, there's opportunities to put programs and practices into place which will increase access to care. And we're in favor of that. And it needs to be good access to good care from good organizations. And we need to look at cost, and we need to look at provider availability and filling in the mismatches in care. Next slide, please. So this is the references that this talk was built upon, and we want you to be able to look up any of those numbers. Happy to share the slides with you. Next slide, please. This is how to connect with URAC, and I want to be clear with you. The email in the middle there, sgriffin@urac.org. That's my own personal email address. Nobody gets that. That's not about sales. That's not about selling you anything. That's about following up on things. If you have questions, if you're worried about whether my bloody nose is going to come back or anything like that, you can throw me a note, and happy to follow up with you and talk to you about it. Also, if you think of something 5 minutes from now, I was an old family practice physician. Sometimes the best questions popped up an hour later. Drop me a note, ask me questions. You can go see our standards at a glance on our website and take a look at what makes up a full program when it comes to telemedicine. If you want to be more involved with us, let us know. Sales and new accreditation inquiries, that's the number, that's the email address at the top. Not too concerned about that. We really do this because we think that there's an opportunity to set a higher standard for care across the country and across the world. And that's why we come into the office every day. So I thank you for your time. I'll open it up to questions. I'm not seeing anything in the meeting chat. You guys are probably all populating it on Whova. But I thank you for your time, and I'm doing much better. Thank you very much.
Thank you, Shawn, so much. I'm glad you're feeling better, for sure.
Well, just to be honest, my allergies are acting up, and I have a problem that when I blow my nose, I blow my nose too hard. I'm so glad this is going to be recorded. And I walked over from a meeting in another part of DC, and my nose was running, so I blew my nose and I got a bloody nose, and I thought I had it under control, and then I'm talking, and all of a sudden, problem. So I'm doing much better. You never know when it's going to get me again, though. So sorry about that.
I can definitely sympathize. My allergies are terrible, so can relate. But I'm glad you're doing better.
Yeah.
As mentioned, now is a great time for questions. So if you have them, please enter them. Either option is fine, through Whova or through the Zoom window. I do have two that I'll get you started with for Shawn. So the first one, submitted by Philip, is asking, have you ever worked with Hero Health, a program utilizing RTM codes with a focus on reducing suicidal ideation through scheduled medication management?
I am not familiar with their work. I can tell you that we work with a lot of organizations. One of the rules that we have in accreditation is we don't announce who we're working with until they achieve accreditation, because if we work with somebody and they don't achieve accreditation, we feel like that's a little bit of a slap in the face. But I'm not familiar personally with the Hero organization, but always happy to learn more as we work on these things. We did have an advisory group when we did our latest update on our standards, and we had a number of organizations who participated in that, but they were not involved in any way that I know of.
Okay, great to know. The next question was submitted by Teresa, asking, do you have strategies for introducing mental health wellness services to California public schools? They are familiar with the Cal Well and Cal Stop programs, but any other strategies?
We have not had any focused efforts in anything in California. We, as an accreditor, we work with regulators and we advise regulators. I don't think we've talked with anyone in California about this. We've talked with people in Washington, D.C., including some representatives from California, but we are not currently engaged with anyone in California on any specific efforts like you asked.
Okay, great to know. I'm sure there's some opportunity. Also asking if you could expand a bit on the Arkansas school-based mental health program.
Sure. So the group is AR Care. They're actually featured in our telemedicine white paper, which I think is on our website. And what they were an FQHC, and they were using telemedicine to provide behavioral health support for elementary schools and middle schools in rural Arkansas. And what they were finding was that the telemedicine allowed them to be much more efficient. In the old days, they would have to put somebody in a car and drive out to the school and spend a half day or something like that. And when you have
Okay.
distributed schools, it's kind of a waste of time for a lot of the driving. And what they built was a program to where was virtual access. So you'd have a central sort of a hub and spoke sort of design where the schools could have access to behavioral health support without having somebody drive there. And they were able to make use of that with the loosening of rules during the pandemic, and they came
Mhm.
to us for accreditation, and they achieved accreditation. And as I said before, going through accreditation, honestly, most of us who have experience in healthcare would probably come up with 80 or 85% of the things that make up an accreditation. It's that other 10 or 15% that you wouldn't think of because you haven't dealt with hundreds of organizations like we have. And
Yeah.
because of our view across the whole industry, we bring in best practices to people who otherwise hadn't stumbled across them. And AR Care is a great little organization. It's really funny to me to think that we accredit a program like AR Care, a little FQHC, and people will say, well, your accreditation is too expensive. And I'm like, an FQHC went through it. It wasn't that expensive. And it's just a matter of having somebody dedicated to quality. And then we also credit somebody like a huge commercial player in the market like Amwell. And they're being held to the same standards. And I think that's a good thing for people who receive care.
Yeah. Great points. I know for CTRC, when we're doing our trainings and technical assistance quality, continuously measuring and tracking your progress and measurable outcomes is super important. Something we try to emphasize, but great to see these real life examples. And obviously with URAC, it's a further more accreditation than CTRC offers. So lots to see, lots of great education shared in this session. I'm not seeing any more questions,
Okay.
so just another reminder for folks, if you have them, now is the time.
I do want to say, Aislinn, I do want to
Yeah,
say, we thank you guys for the invite. We wanted to come here. We wanted to share our experiences. This was not about selling anything. This is about all the places that we look and all the things that we see. And when it comes to California, I mean, you guys are doing some things where you're out ahead of it, and we appreciate that. And there's other things where these rural issues, these provider mismatch, these deserts of providers. We think that having organizations that appreciate the challenges that we face.
yeah,
The other thing I would say is if you're a fan of telemedicine and telehealth and what you're doing, please promote what you're doing to your representatives.
yeah,
Because I can tell you, being here in Washington, D.C., I mean, the congressmen, the senators, they have people talking in their ears all the time. And those messages do not get as much attention as a message from somebody who they're actually representing. So
yeah,
a person from the town that you're elected from is worth 10 times the opinion of somebody who's a paid lobbyist coming in their door on a Thursday. So please share the good examples of telemedicine and telehealth and behavioral health with your representatives, because they're going to read the bad examples in the paper, and
mhm.
and they need to have some good to outweigh the bad if you want them to be a supporter of what's being done.
Yeah, great point. This is very true. I know they want to hear from people, boots on the ground, folks,
Yeah.
doing the work, real experiences. We love to know also for CTRC, we'd also love to hear your telehealth success stories. So yeah, we have some on our website available from just to demonstrate where success can be found with telehealth in a variety of different settings, but we're always looking for new stories, new successes. So yeah.
And go to our website, get our white paper. It's got some examples of good telehealth, leaders and the things that they've been doing. And just thank you guys all for what you're doing to promote telehealth at CTRC, and also all the organizations that have attended, for taking time out of your day to look at these things and to try and learn and share your best practices. We appreciate the fact that you're out there delivering care and trying to make a difference. So thank you very much.
Thank you, Shawn.
Okay.
Appreciate the support. Okay, well, I'm not seeing, let me check one more last check. Just some feedback. It says, thank you very much and great session. So I think We are good to wrap it up. Thank you, Shawn, so much for your time and all the insights you shared here today. Everyone online, I hope you will join us for our next sessions focused on language and culturally competent care, language translation, and those themes. So we're looking forward to that next session. But thank you so much, Shawn. We appreciate you. So
All right. Thank you guys. Bye from Washington, D.C. And I'll go back to my allergies now. Bye.
bye. Good luck.